Hello, everyone. My name is Allyza, and I will discuss the clinical management for David Nasal, a 62-year-old male affected with COPD associated with COVID 19 infection. Using A to A assessment, we will assess his condition to inform our decision. Furthermore, we will identify the four high priorities in nursing intervention and examine the key nursing considerations for administering medications. Now, let's start with A to E assessment in COPD exacerbation to evaluate Mr. David Nasal condition. Airway. David airway is clear. There is no signs of obstruction in his breathing. However, we should continue monitoring for significant change considering the production of yellow phlegm and respiratory distress to prevent possible airway obstruction. Next is breathing. As per oxygen guidelines, the suggested oxygen saturation level for patient with COPD should be 88 to 92%. David's respiratory rate of 30 breaths per minute, oxygen saturation level of 78%, hyperinflated lungs with reduced breath sounds as well as wheezing and crackling sounds indicates an airway obstruction, which results in low blood oxygen. Furthermore, the result of his arterial blood gas test show lower level of pH at 7.30 and increased carbon dioxide of 60 millimeter of mercury evidence a respiratory acidosis. These findings accentuate the necessity of enhancing his oxygen level and improve his breathing by administering a bronchodilator, supplemental oxygen, as well as settling him in Fowler's position. This will help to open his airway, thus prevent him from further deterioration. Now, let's move on to circulation. David is tachycardic. His heart rate is 128 beats per minute, and his blood pressure is also elevated at 168 over 85 millimeter of mercury. These symptoms indicate his circulatory system is compensating in response to hypoxia and distress. Furthermore, his capillary refill of 3 seconds and cool extremities indicate a poor blood flow tissue. Therefore, close monitoring and performing 12 lead ECG 6 hourly is vital to monitor his cardiac function in case of complications. COPD patients are 2 to 3 times more at risk of developing cardiovascular problems and mortality, which is linked to the severity of the disease. Furthermore, transferring him to the high dependency unit is essential in the event of deterioration. Disability. David is confused and distressed with a Glasgow Coma Scale equivalent to 14, and that may be due to have severe hypoxia. In this case, close monitoring of neurological status is essential. Furthermore, the patient may require an admission to a specialized respiratory care unit if the condition of the patient does not improve despite of administering of supplemental oxygen. And lastly, exposure. David has fever, which is an indication of inflammatory response due to infection. Sputum culture and administering of intravenous erythromycin is necessary given his yellow phlegm could be a sign of bacterial infection. Furthermore, giving him antipyretic could relieve his fever and improve his comfort. He should also isolate and comply with infection control precautions to prevent the spread of coronavirus. Now, let us discuss the four high priority nursing interventions for managing COPD exacerbation in Mr. David Nazal. First is controlled oxygen therapy. The utilization of oxygen therapy is the only treatment that improves the survival of COPD patients. Furthermore, for the majority of patients, the aim is to maintain their oxygen saturation level more than 90% to reduce the severity of exacerbation. In the case study, David's oxygen saturation is only at 78% and his arterial oxygen partial pressure is at 55 millimeters of mercury. Therefore, administration of oxygen is crucial to prevent further hypoxia and hypercapnia. Second is the use of bronchodilators such as salbutamol. Bronchodilators used as a primary treatment to alleviate dyspnea. This works as a bronchial smooth muscles relaxant in the airways, consequently promotes ventilation in the lungs. This medication will help David improve his breathing, hence enhance his respiratory function. Third is the use of corticosteroids. According to Lung Foundation Australia, Cochrane researchers found inhaled corticosteroids to be beneficial to prevent COPD exacerbation. Corticosteroids reduce airway inflammation. By reducing David's airway inflammation, his lung function can improve, thereby enhancing his recovery during exacerbations. And last is patient isolation in a negative pressure room. In the case study, David is COVID positive, therefore, it is essential for him to isolate in a negative pressure room and apply infection control precautions. Through this measure, the spread of the disease will be prevented, thus protect the other patient and healthcare providers in the hospital. Now, let's move on to the nursing consideration for administering therapies and medication in COPD management for Mr. David Nasal. First, we have oxygen therapy. When administering oxygen to David, nursing considerations such as following Australian standards for appropriate dose, method of administration, proper handling, and instruction is vital. Furthermore, monitoring patient for serious side effects such as dizziness, pain when breathing, vision problems, irregular heartbeat, sudden headache, fainting, as well as following the guidelines for oxygen concentration to prevent oxygen toxicity, and ultimately, continuous monitoring the patient during the treatment to reach the desired arterial saturation at the lowest possible level of inspired oxygen. Second is salbutamol and ipratropium nebulizers. Salbutamol and ipratropium can cause severe hypokalemia for higher dose. Therefore, appropriate dosing and care should be taken when administering as well as educating the patient of proper using the device. Furthermore, this medication can significantly relieve Davis dyspnea, but careful monitoring of his vital signs is crucial as this may cause arrhythmia and tachycardia. Third is prednisolone. When administering prednisolone, it is essential to educate the patient on how to use the inhalers, spacers, or nasal spray and instruct them to rinse their mouth with water after each inhalation to prevent oral thrush. Furthermore, observe for severe side effects such as intestinal pain, epileptical fits, sudden changes to vision, dizziness, fainting, chest pain, irregular heartbeat, and psychiatric disturbances. Fourth is nirmatrelvir and ritonavir. For nirmatrelvir and ritonavir, assessing David's renal function before and during course of the medication is vital. Systemic exposure to nirmatrelvir rises if a patient has kidney problem, which aggravates renal impairment. Furthermore, be aware of any drug interaction with other medication that David is taking, as well as severe side effects he may experience, such as vomiting, diarrhea, headache, changes in taste or metallic taste, abdominal pain, and severe allergic reaction. And lastly, azithromycin. When administering azithromycin, monitoring patient allergic reaction is essential. This drug is linked to rare and serious allergic reactions such as acute generalized exanthematous, pustulosis, Stevens-Jones syndrome, and toxic epidermal necrolysis, and drug reaction with eosinophilia and systemic symptoms. Furthermore, monitoring for side effects such as vomiting, headache, spinning sensation, severe persistent diarrhea. Prescribers should also review the prolongation of the QT intervals, as this can be fatal. It is also linked with arrhythmias such as ventricular tachycardia and torsades de pointes. In conclusion, David's COPD exacerbation requires thorough evaluation and focused intervention. By utilizing the A to E approach, we prioritize care and ensure patient safety while optimizing treatment efficacy through administering essential medications and practicing nursing considerations. This knowledge not only promotes patient outcomes but also enhances quality of care. That's the end of my discussion. Thank you for your attention.